Good afternoon and welcome to today's webinar, Improving Linkage and Retention in HIV Care, Insights from Community Health Workers. Please know that this webinar is being recorded. This webinar is the third in a series associated with a cooperative agreement titled Improving Access to Care, Using Community Health Workers to Improve Linkage and Retention in HIV Care, and is funded through the Secretary's Minority AIDS Initiative funding and the Health Resources and Services Administration. This cooperative agreement spans from 2016 until 2019 and is administered by HRSA's HIV/AIDS Bureau in the Division of HIV/AIDS Programs. Thank you so much for attending. At this time, I'd like to give you a few bits of technical information. We're asking all attendees to ask questions using the Q&A icon that you see here next to the thick red arrow. If for some reason the Q&A icon isn't working for you, you can also use the chat box. And my colleagues Rachel and Maria are here helping me track your questions, and we will answer as many as possible at the end of the presentation. Some questions, if they can be answered quickly, Rachel and Maria will be answering as we go along. With that, I'd like to turn it over to Dr. Linda Sprague-Martinez.
Good afternoon. It's my pleasure to welcome you all to this afternoon's webinar as we get started. My name is Linda Sprague-Martinez, and I'm the Principal Investigator of the HRSA-funded initiative Improving Access to Care, Using Community Health Workers to Improve Linkage and Retention in HIV Care. I'm also an assistant professor at the Boston University School of Social Work in affiliated faculty with the Center for Innovation in Social Work and Health. Thank you again for attending today's webinar, and now I'll invite Allison Bowman, our project director, back on to walk you through the next phases of today's discussion.
Thank you so much, Linda. As previously mentioned, this webinar is the third in a series. You can view the other webinars on the Center for Innovation in Social Work and Health website and at Target HIV. And we'll share the links to these two websites at the end of the presentation. Our agenda for the presentation is to go through a few learning objectives, cover the Community Health Worker Project and its goals. I'll introduce you to our two main speakers today. We'll talk about models of care and activities in the field from our CHW presenters. And we're really excited to have a question and answer session at the end. So the goals of today's webinar are to provide you all with a brief overview of this Community Health Worker Project and the goals of project activities, to describe two models of care where community health workers have been integrated into the care team at two Ryan White HIV/AIDS program-funded medical provider sites that are participating in the project, to provide current examples of the job roles and functions of community health workers by community health workers themselves, talking about their work experiences in the field. And as I mentioned, to provide a time for questions and answers from all of you attending today. So at this time, I'd like to provide a brief overview of the Community Health Worker Initiative on which this webinar is based. As I mentioned, this is a cooperative agreement funded through the Minority AIDS Initiative Fund of the Secretary of Health and Human Services. It's administered by the Health Resources and Services Administration, HIV/AIDS Bureau in the Division of Community HIV/AIDS Programs. And this 3-year project is funded by the Bureau, and Boston University is funded as the Technical Assistance and Evaluation Center for the project. The 4 goals of this initiative are to increase the utilization of community health workers in order to strengthen the healthcare workforce, improve access to healthcare and health outcomes for people living with HIV, especially racial and ethnic minority individuals. To assist Ryan White HIV/AIDS program-funded medical providers with the support they need to integrate community health workers into their multidisciplinary teams. To develop tools, materials, and resources to help increase the use of community health workers in HIV care settings. And finally, to evaluate the effectiveness of community health workers on linkage and retention in HIV care, and to assess community health worker models that are implemented by Ryan White HIV/AIDS program-funded providers. As the funded Technical Assistance and Evaluation Center for this initiative, the team at the Center for Innovation in Social Work and Health at Boston University employed a competitive process to select the 10 sites that we were working with on this initiative. This map shows the 10 funded sites that we've been working with on the project. And as you can see from the map, the sites are scattered all across the country. The 10 funded sites are about 70% urban and 30% rural, and they're focused in areas that serve a high proportion of racial and ethnic minorities living with HIV. And these areas also comprise locations where retention and viral suppression rates are much lower than the US average. This slide shows a brief overview of the initiative. Later in the year, we'll be conducting a more in-depth webinar on the project, lessons learned, emerging best practices, highlights from 2 training curriculum we are developing, and other information about implementation. And since you're registered for this webinar, we will be automatically notifying you of that webinar and other future webinars using your information. And be sure to be on the lookout for HRSA announcements for future webinars as well. So in general, for this project, we're interested in developing an effective model that successfully integrates community health workers into HIV multidisciplinary treatment teams. We're providing the 10 CHW sub-award sites with training and direct technical assistance on implementing community health worker programs. We also created a space for peer-to-peer learning on the project, which we're calling learning sessions. And we're conducting a multi-site evaluation to assess the effectiveness of project activities, including the CHW program activities at each sub-award site. Later in the summer, we'll be starting to disseminate our main deliverables, including a community health worker implementation guide, and as I mentioned, 2 training curriculum. Now it's my pleasure to introduce our 2 community health worker speakers who've been participating in the initiative. The first presenter is Peter Williams, a support specialist CHW at East Carolina University Adult Specialty Care Clinic in Greenville, North Carolina. And our second presenter is Savvy Bailey, a community health worker at Legacy Community Health in Houston, Texas. So I'd love to welcome Peter and Savvy and invite them at this time to tell you a little bit about their agency. Peter, why don't you start us off?
Thank you very much, Allison. Good afternoon, ladies and gentlemen. My name is Peter Williams, empowered as a community health worker support specialist at ECU Adult Specialty Care Clinic located in Greenville, North Carolina. It is my honor and privilege to share insights with all the attendees on the webinar today. Adult specialty care accommodates general infectious disease care, hospital follow-up, clinical trials. We have an on-site lab, an infusion center, as well as an international travel clinic. Our adult specialty care clinic also implements an ID fellowship program, serving about 600 Ryan White eligible clients from 30 rural counties on the Eastern Carolina coastline, working with a professional staff of roughly 50 members, including medical providers, behavioral health counselors, a nutritionist, PharmD, nursing, and medical case managers. I am one of 3 community health workers empowered in the retention of care by navigating HIV consumers through chronic illness quality healthcare supportive services. As you can see from our state view, this map shows the counties in North Carolina that are served by the ECU Adult Specialty Care Clinic. The area we serve is very rural, with some individuals traveling over 1 hour to appointments. As a result, providing services to the rural community presents unique challenges in reaching our target population over this vast region. My esteemed colleague, Savvy, will now introduce you to Legacy Community Healthcare.
Thank you so much, Peter. Hi, everyone. I'm Savvy, and I work as a CHW at Legacy Community Health in FQHC in Houston, Texas. We serve many clients, as you can see on this slide, both Ryan White and non-Ryan White clients. We have over 25 sites across Houston and the surrounding area, though our HIV healthcare is focused at 2 of our clinic sites. Our area, Houston, is mostly urban, but because it's so spread out with the city structure, many of our clients travel pretty far distances to get to us with a sometimes dysfunctional public transportation system. We're a staff of over 1,000 employees that do many of the services that you see here on this slide. As you can tell, we extend far beyond just HIV medical care, which allows our clients to come in for a variety of needs all at once. I fall under the public health department, where I'm one of over about 10 CHWs, but I'm the only one working solely with clients who are HIV positive and struggling to stay in medical care, and the only one on this project. Some of our other CHWs work in outreach education or STD testing, which I'll touch on in a later slide. Back to you now, Allison.
Thanks so much, Peter and Savvy, for that information about each of your agencies. Let's talk about your CHW program next. Peter?
Thank you, Allison. Here at East Carolina University, community outreach and support services are the fundamental building blocks of our healthcare team approach. As you can see by the diagram, the client is at the center of numerous services provided in the Ryan White program. I will briefly walk you through the model and talk about the points of care in our program, which is set in motion with the ID provider scheduled in clinic. Every client being assigned to a healthcare provider, completing the intake process, whereupon a dedicated medical case manager conducts an assessment to evaluate barriers to care with behavioral health services, which screens for mental health and substance abuse disorders through the HIV care continuum, is linked with the team medical case manager who is staffed with the provider in the clinic. Following the assessment of the patient's Ryan White eligibility, type of insurance coverage, proof of income, prescription assistance programs in collaboration with PharmD may be required. Our client is then assigned by a supervisor based on the agency criteria to the CHW, completing the circle of client care in our multidisciplinary team model. The tools of motivational interviewing, trauma-informed care, and client interventions coupled with home visits create a concrete foundation in assessing stigma, ambivalence, and social determinants of health for our consumers. The CHW has the capacity to link clients to multiple resources due to the lack of transportation. For example, Social Security Office, Salvation Army, social service, food banks, optical and dental, and other referral ambulatory services. Support specialists advocating through the communication of a client's deficient coping skills becomes a buffer for the low literacy level of the consumers found in some of the rural counties we serve. Savvy, would you please share Legacy's model?
Absolutely. So in discussing the CHW program at Legacy, we are similar to ECU regarding, in their model, regarding different positions working together with the client. I like to think of it as a bridge. However, we're different from ECU in how we obtain our clients. For our program, I take all clients that are referred to me, but in addition, I also created most of my caseload by seeking out clients through our electronic medical record system, or our EMR. With many departments all potentially working with a client on multiple health issues, some essential things we've had to keep in mind are role distinction and communication as the key to being able to all work together. As you can see from this model on the slide, my referrals come from about 5 sources. As I said, initially I was finding my clients through the EMR by specifically searching for clients that had a large number of no-shows in the past 6 months or a year, or ones that were in care but struggling to stay virally suppressed. However, as the program grew, the case managers started referring clients to me who were having trouble with their funding sources expiring, or they just needed more concentrated time for education or referrals or assistance, things like that. So I started to help get these clients qualified for Ryan White and back in care, and then would transition them back to the case manager. I also started receiving referrals from our service linkage workers who are based out of the case management or social services department. They do home visits and they work with clients who are struggling to stay in care, similar to me, but they're restricted to working with clients whose Ryan White is unexpired. So they would refer clients to me who are non-Ryan White. I could then get them into the clinic, get them back on their funding source, and then work with the service linkage worker if they still needed a home visit. Another one on this slide that you'll see is M Society. This is another one of my referral sources. They're a men's empowerment group that operates out of a community center that's based within Legacy, and it's where my office is. They will sometimes have clients come in for events or STD testing who they'll, through conversation, identify as being out of care and wanting to be linked back in, and they'll transfer them to me as clients. Lastly, as I mentioned, we have a lot of CHWs in our departments. Some of them do STD testing, and they'll occasionally also identify clients who maybe are coming in for syphilis testing, and then through the conversation find out they're out of care for HIV care and want to get back in. So again, they'll just connect them to me. So I'm working with clients that are not newly diagnosed. They're ones that just for some reason or another are out of care. Through these 5 systems, I've really been able to build up my caseload, and I now have over 100 clients. Back to you, Allison.
Thanks again, Peter and Savvy. Now that we've heard a little about your organization and the CHW programs that your organizations are implementing, let's spend some time hearing about what you do on a daily basis as a CHW. Peter?
Here we go, Allison. Our team model promotes a weekly huddle with the team supervisor and all the CHWs. We then case conference our client barriers while addressing definitive alternative resolutions. The bedrock of our outreach begins with assessing our client on their turf and in their space, having the flexibility of meeting clients, say, in a library, in a park, a local eatery. The conference room could be in a library. It may be here at the clinic. We can also go to the resident's home for that home visit, but ultimately we're looking for a safe space to have that truly one-on-one courageous conversation. every client is simply not always transparent in a clinical setting where this pragmatic procedure has proven to architect this consumer relationship with our independent client, as well as strengthen community partnerships. Through motivational interviewing techniques, including coaching, emotional support, and trauma-informed care, the CHW analyzes the client chronic illness knowledge base and will administer educational modules such as HIV 101, helping the client to communicate with the healthcare provider. We have a module to help understanding what is the CD4 count, the viral load, opportunistic infections, sexually transmitted infections. We have a course on understanding HIV medication and the importance of adherence. We teach our customers goal setting. And lastly, we have an educational module for social support and disclosure, where they are applicable for the consumer interventions. The CHWs routinely assess our clients based on a 3 to 6 month benchmark window with the supervisor for the transition of a modified intensity level, where a client is either self-managed, moderate, or at an intensive level. The adult specialty care houses 3 dedicated CHWs, all supporting HIV, whereby the supportive services and special projects range from transportation services via Medicaid, gas vouchers, bus passes, taxi cabs, as well as having a clinic van for scheduled provider visits, and to our food pantry, managing over roughly 55 appointment, ridership transactions that are coordinated monthly in conjunction with various provider appointments as the adult specialty care clinic caseload dictates. Another designated CHW coordinates target housing as the adult specialty care operates as a referral agent and facilitates quality improvement consumer training as a special project, in addition to each one of us executing a calibrated caseload in which the individual client service is documented through the electronic medical record as well as the CareWare system. Our adult specialty care has a life skills support group which meets every second Wednesday of the month at our clinic with the consumer input and education via Lunch and Learn campaigns, which strengthens the fabric of people living with HIV in the rural communities that we serve. We have created a lifeskillsupport.org website to educate and inform consumers by providing more visibility of services offered in our Region 10 network. As a CHW, our consumer is passionately empowered for the self-management and self-advocacy in maintaining quality healthcare outcomes for the HIV chronic illness disease spectrum. I'd like to now turn it over to Savvy to share her experiences at Legacy.
Thank you, Peter. As Peter was kind of saying at the end, my role, and I think Peter would agree completely with this, is that as a CHW, our role is to support clients and get them back to a place where they're able to advocate for their own needs. Unlike ECU, though, we don't do this through huddles. We don't do huddles. I work specifically with providers and case managers when needed at the clinic or with clients at the clinic. I also operate out of our drop-in center, as I mentioned, but much of my time is spent building rapport with clients over the phone before they ever even come back into the clinic. So I don't do house visits or community visits currently, but it's something we're moving towards in our department once we can get the protocol down. Much of what I do is connecting clients with the right resources or the right folks to connect with. As Peter mentioned, they have a transportation van. We don't have that, but we can provide bus passes for our clients. We also don't do housing out of our case management team, but we would refer externally for that. Besides that, though, our more unique part of our organization is how many services are housed under our umbrella. Much of my position involves coordinating clients' internal referrals for other services because these are needs that are getting in the way of their care and there are reasons they're not coming back in. So I had one client who was really struggling with his health and fitness and eating, and that was affecting how he was taking his medication and really being able to keep himself healthy. And I was able to refer him directly to our in-house nutritionist, and we have a gym on site at his medical visit so that he could do all of those things in the same place. And all of this works together to really build rapport with clients and help them solve some of their needs. Education-wise, a lot of what I do is unofficial education. I have done some more official education curriculum sessions with clients around medication adherence and lab results, but I think the majority of my time is taught educating clients about how to get their medication, what systems are in place to help them pay for their medical care, and the community resources they can utilize. These three things are some of the main reasons my clients list for why they're struggling to stay in care. I get a lot of my community information through the Ryan White Planning Council, where I serve on the Quality Improvement Committee here in Houston. Differently again from ECU, I never have an end date with my clients, and each of them I'm in contact with depending on their need. Some need weekly phone calls or more, depending on what's going on in their lives, and then some just need a call every month or two. Maybe they need a reminder or just to feel like they're connected to something. So that's how I'm currently operating with my caseload. Back to you, Allison.
Thanks again for all this great information. Before we open for questions and some more discussion, I want to allow Peter and Savvy to each share a brief client story with you. Peter, can you start us off again?
Absolutely, Allison. I wanted to share, as I was briefly looking over some of the questions, and I didn't know exactly how we were going to answer, but someone asked, is U equals U incorporated in the client education, and if so, at what point, and who is communicating the message, and how's that message being communicated? I did want to add, when we go over HIV 101 and we take the client through the bases, we do educate them about the U equals U campaign. So it is done up front with the client so that they do understand a comprehensive understanding of the chronic illness, and that our goal in achieving viral load suppression 6 months and greater, you're no longer infectious. You're not transferring the virus to anyone through contact. So thank you, Allison, for allowing me that moment. I'm very excited to share this success story. It begins with a 57-year-old African-American male diagnosed in 2005 with AIDS, living in a homeless shelter in Washington, North Carolina. While re-engaging in care, he consented to our CHW initiative in November of 2017. The labs at the beginning of 2018, there was a viral load of about 159,000, and the client CD4 count was 4, single-digit 4. The barriers of care were no direct telephone communication, unstable housing, poor diet, lack of transportation, substance use disorder, and non-adherence to antiretroviral therapy. The behavioral health services determined that our client was incapable of performing activities of daily living. During February of 2018, our client's mother informed the CHW that the patient had traveled to a neighboring town away from where they were and was arrested for vagrancy and was currently out on bond. Our client's mother is living in her 80s under the duress with the hardship of being unable to care for her son. Under all the challenges, housing assistance for the client was the major priority. Exploring all of the available options through case conferencing and teamwork, in about March of 2018, our client was placed in an adult living facility in New Bern, North Carolina. And as of May of 2018, our client had achieved viral load suppression. And this client's CD4 count had now at least reached into 2 digits of 27. So you can understand that his immune system had truly been compromised. As a CHW, building the relationship with the client has been extended to close communication with the mother of our patient for flexible, effective boundaries of care. Our client, as of a visit this year in January, is still viral load suppressed, and the CD4 count is now at 162. He's currently working odd jobs, signing himself in and out of the adult living facility, yielding personal income while gaining weight, maintaining a healthy relationship with his family, and a very proud mother. The relationship building is the very core of what keeps our client engaged in their care. Because you have to remember, this was a homeless client, no communication with telephone, and his mother desperately trying not to lose her son. Our client, under the guidance of behavioral health services, is pursuing nicotine dependence treatment. And if you heard this story, part of the barriers were substance use disorder. His follow-up provider visit just this past April, last month, resulted in sustainable viral load suppression and a 205 CD4 count. As a CHW, these social determinants of health were the insurmountable challenge for our client's success. In about a year's time frame, this client turned his situation around into sustaining viral load suppression. And I can just tell you, I am very, very pleased for the turnaround, and I'm very, very grateful for the work that was placed into this client living with HIV. Savvy, you have the podium for a legacy CHW success story.
Thank you, Peter. So my story is a little bit different because my client is still struggling with care and his medication. He's about 30 years old and was diagnosed with HIV at least 5 years ago. I started working with him in February of last year when he had not been in for a medical appointment with us since 2014 or 2015. When I was finally able to reach him by phone, I found out that one of the reasons he wasn't in care was because his financial situation had changed. He had started only working barely part-time and was going to school full-time, and so he didn't really know what options were available to him. He had insurance but was having trouble paying the bill for it. Legacy offers financial assistance programs that help clients pay for their premiums on insurance. So I was able to get him in on that assistance and then to also get him on Ryan White and ADAP medication assistance to help with anything that his insurance wouldn't cover. At this time, he no longer has insurance, so his Ryan White and his ADAP have been vital to pay for his medical visits, his labs, his medication. When I first started working with him, he told me that he can't swallow pills. So I looked back through all of his medical records and visits, and he had never told his doctor this. And directly from his last visit, it was reported that he said excellent adherence with HIV meds, with no issues in understanding his medication or responding to it. So through discussions with him, it turned out that ever since he was a child, he hadn't been able to take pills, and instead he just sucks on them until they dissolve, which for some medications, that's totally fine, but his HIV medication was time release capsules, which means if he was swallowing it, he was swallowing incorrect amounts of his medication, it wasn't dissolving correctly, and then wasn't being absorbed properly in the body. This was also making him very sick, and he was vomiting pretty regularly, which then also made it so his medication wasn't being absorbed. But in his mind, he was taking his medication, which is why he kept reporting that. What followed for me was work that required hours and hours and hours of time to assist him. So first, I worked with him on some swallowing techniques to try to see if it was something we could get past. When that didn't work, I was regularly working with his provider and the case manager to keep them informed and to then try to work to address medication changes. So we had to get our pharmacy involved to make sure there were liquid versions of all of his medications, and then we had to get medication assistance programs involved to help him pay for it. At the same time, he was in school and working, and he kept missing appointments because in his mind he was fine, he was taking his medication. So there was this gap further and further when his labs were being done. So when we finally got him back in, got him on liquid meds, and got him to do a lab, it was clear that the last 5 years of incorrectly taking his medication was really starting to show in his labs. And to keep in mind, when we first worked with him in 2014, his CD4 was only at 296. So his numbers were already, to begin with, very low. So for the past year, I think I was trying to figure out how many times I maybe have spoken to him. I think I've spoken to him on the phone at least 50 times. He's been hospitalized a few times in this past year, and so I visited him in the hospital twice. In this past year, I've changed his provider once so that we could get him on a provider that had a more open schedule for his flexibility. I've worked with him to update his Ryan White and his ADAP as they expire yearly. I've also worked with him to help him disclose to his mother about his diagnosis because he hadn't told her yet. He's switched medications at least 3 times in the past year. At my best guess, I've probably spent 10 times the amount of time on his case than I have with any of my other clients, and they're pretty difficult clients to begin with. So while this isn't the best success story because he's still hospitalized, he still has trouble with his medications, even his liquid ones, because he got pretty used to vomiting and still sometimes does that and doesn't quite understand. He does keep coming back to us, and he's calling now to cancel any appointments. He never no-shows. He'll schedule his hospital discharge directly from the hospital. He will call ahead to get a wheelchair if he's feeling weak that day. So while he's still struggling, he's really starting to advocate for himself. And so it's clear through this past year working with him that a provider or a case manager don't necessarily have this kind of time to put in with a client. And we would have maybe had some more success sooner if this had started sooner, but either way, it's clear that the rapport between the two of us is super important, and it's got him to really trust the clinic and feel like he can come in and advocate for himself. So my hope is that with more visits, we'll see him doing better and better, and that this program has really been very important for his life and his health.
Thanks so much for those really valuable and important stories. So we want to thank our partners and colleagues for their help and support throughout the initiative and also on this webinar today. Starting with our HRSA project officer, Brian Fitzsimmons, I want to extend our thanks to the 10 Ryan White provider sites that are working with us on this initiative as listed here. And finally, I want to say a special thank you to my group at the Center for Innovation in Social Work and Health, Linda, who you met briefly at the beginning of the webinar, and my colleagues, especially Rachel and Maria, who are working behind the scenes with us today. So now we'll spend some time. We have a good 20 minutes to spend some time on questions and answers. As we mentioned before, please try to use the Q&A function to ask questions. We'll answer as many as we can. For those questions that we are not able to answer during the time we have left, we will be making every effort to answer them offline and sending out a document of questions and answers to all participants of the webinar today. That question and answer document will also be posted on our website and on Target HIV, along with the slides and the recording of today's webinar. So we have quite a few questions that have been answered. I'm going to try to start going through them for Savvy and Peter. So starting with one that Peter already addressed, we just wanted to give you an opportunity to answer if you had any information, Savvy, about whether U equals U is incorporated into client education, and if so, what does that look like?
Sure. So I think similar to Peter, that's kind of incorporated throughout the whole process. I think it varies depending on the client, because some of my clients are really aware of this information. It's not necessarily the education about HIV. It's more that they have barriers in their lives that are separate from HIV. So it may be that someone's really aware of HIV and U equals U and all of that, but maybe they're having trouble with their housing. They don't have stable housing, and so they're not taking their medication because they don't have a safe place to do it or a safe time. But definitely U equals U is something that I will always talk with clients initially to try to kind of find out what their understanding is on HIV to get a baseline for what education they may or may not need.
Thanks, Savvy. Okay. So Mahara asked, our program does everything that you all have mentioned, and they're also a substance abuse treatment center. And many of their HIV positive clients have substance abuse concerns. Do either one of you all refer clients to substance abuse treatment?
Allison, I'd like to take that.
Sure.
Well, at the clinic, we start with our behavioral health services. And once they've determined that there is a substance use issue, I personally, as a CHW, have had a client that I transported in the clinic van to a substance abuse center a distance from where we are. I don't know how familiar everybody is. Raleigh is the capital of North Carolina. So we do, in fact, work with the client to place them in a substance abuse treatment center. If that is the recourse, as Savvy alluded to, a lot of times HIV might be the chronic illness, but it's the barriers that the client is truly dealing with. So the short answer is yes, we certainly do facilitate helping a client with a substance abuse treatment center.
And for me, what I'll do is, because I can't diagnose a substance abuse disorder, sometimes I will, or some substance use disorder, excuse me, I will transfer them also to behavioral health or a case manager. But we do have internal tobacco cessation, which is I can refer them to.
Great, thanks. So Eli has a question. Eli says that they work as a CHW for an HIV prevention research center at Children's Hospital in Philadelphia, and they're new to this line of work, and they're interested in hearing about what resources you all use to help your skills in motivational interviewing, and resources that you might find helpful as a CHW in general.
I could say that we have an ongoing in-house training, whether it's through a lunch and learn, whether it's through a webinar of this type, but we have a individual, they're actually part of the behavioral health staff, and we have a monthly training session or meeting for motivational interviewing that is ongoing for us. And we have to attain certain levels of the technique. So for my center, the infrastructure is an ongoing motivational interviewing training in-house.
For me, externally, I've done a few trainings through the CDC. They have a motivational interviewing one. They have a testing one, a HIV testing one as well. So if you look on the CDC's website for some of their trainings, I believe it travels all around the country for motivational interviewing specifically.
Great, thanks. So NG asked a question about where along the care continuum do you most frequently encounter stigma issues? And how do you help clients deal with stigma that prevent them from staying healthy?
Well, I would jump right in and I'd say all along the healthcare continuum. Stigma is such a sensitive component of HIV care. So you're constantly educating, you're constantly trying to get the client to share anything that might trigger some form of trauma behind a stigmatized experience that they're going through. So I would have to say that it's ongoing. Fortunately for the clinic that I support, because we do have the flexibility of being of doing home visits and meeting the client on their turf. When you're in a client space, you have a better assessment, if you will, of what certain stigmas are. So it's somewhat easier to build a relationship with the client based upon seeing that client in their natural environment. So for us, I know it's ongoing through the HIV care continuum that one may encounter, deal with, and process stigma.
I couldn't agree more with Peter. Stigma is everywhere, and so I don't think there's any one place where I find it more often with clients.
Right. Absolutely.
So here's a question. Here's a question from Amy asking, Savvy and Peter, can you elaborate and talk a little bit about the benefits and challenges of having sort of a set time limit for your work with clients, and not having a set time limit for that work?
I can start with that one. Or Peter, you go ahead. You go first.
No. Savvy, okay. Go right ahead, dear.
Okay, because I saw this one and I was like, oh, I want to answer this. So I think the benefit to this, because I don't have a set time limit, is I'm never rushed with my clients, and they feel that. So they feel like they can open up more. So I'm able to get, I think, a lot more information out of them than potentially a provider or a case manager. That's why I think I got the information about my client's swallowing pills issue, because he felt rushed in his visits. The downside to it sometimes is, especially not having an end date with clients, is sometimes they'll be really successful, they'll be advocating for themselves, they'll be attending their appointments, and then they'll fall off again. So it does sometimes feel as if my work is never done, which is good and bad, I would say.
Thank you, Savvy. I wanted to just build off of what you just stated, that even though we have developed a process to transition a client based upon their own personal intensive level, once we build that relationship up front, we all have a work cell phone, and believe me, we're not going to not assist or not help a client that you've developed a relationship with and they continue to call you. Oftentimes when we're in a season of the Ryan White eligibility renewal, it's probably easier for the client is going to call me and send or text proof of income, pay stubs, if you will, before they even send it to the medical case manager, who in turn actually does the processing. So the relationships are ongoing. So we developed a process so that we have one in place to transition clients. But just like Savvy, those relationships continue, and the client may call us continually, and we're certainly either going to refer or simply resolve whatever the issue is. So we've developed a process, but the relationship is ongoing.
Great. Helene's wondering if you all have any examples of working with clients around dental and oral health care.
Oh, absolutely. We work under the umbrella of East Carolina University, so we have a dental school. So the infrastructure of that referral, as I stated in my presentation, is that we do help the client with dental as well as optical and any other ambulatory referrals that they need. So yes, that is in full effect. We make a referral to the dental school. They set up the appointment with the client, and that is a health area that we do address. Absolutely.
Legacy as well, we have a dental facility in our clinic and also a vision center. I don't find that I'm doing very intensive education necessarily on dental, just because the clients typically have a lot of needs, and they typically know if they have dental issues sometimes. But that is something that I'll refer them to, get them on the wait list for that.
And I just wanted to add, Savvy, you just made me realize, normally in the provider visit is when the referral will actually be made. Like, they can mention it to me and I can follow through with it, but normally that's actually captured in the provider visit.
Great, thanks. We've got a couple of questions around caseload. Dawn is interested in knowing what your average caseload is, and Holly's interested in how you, Savvy, and also you, Peter, how do you prioritize your caseloads, especially you, Savvy, since you have a large number of folks on yours.
Sure, I can start with this one, Peter, if that's fine with you. So I would say so I think I have about 120 clients right now, but not all of them are active. So I will mark some as inactive and some as active, and that helps me organize them. The ones that I put on inactive are ones that I have tried quite a number of ways to reach, and I want to keep them there in case some of those things eventually sink in and they come back in. For my active caseload, it's organized by when their appointment times are or when I've last called them. So there are some that I prioritize higher based on lab results or upcoming appointment needs. And it kind of varies per client, so I guess that's not entirely clear. But I find that some days I don't have enough to do, and some days I'm super, super busy. And so I kind of manage that on a day-by-day basis. And in the future with this kind of programming and clients, I think this will be a decent-sized caseload for sure.
Thank you, Savvy. Right now, I'm working currently with an active caseload of roughly 40 people. As I tried to illustrate in my presentation, being one of 3 CHWs, we have special projects. And so there is a balancing act that we do perform daily. I'm a person that goes by a day planner. So based upon the client scheduled provider visit, based upon the need for transportation, based upon meetings, etc. You basically do have to prioritize, as Savvy is saying, daily. It's just a daily prioritization. Some days are certainly more aggressive than others, but you have to understand the nature of what you do. You could have your day perfectly planned, and all of a sudden you get a phone call, and just like a monkey wrench being thrown into the greatest plan, you have to put out the fire. So it does come with the territory of simply prioritizing on a needs basis. But I do try to be proactive. I try to have everything in a day planner, including meetings. And so you try to really create a balance for yourself. So it certainly is the true definition of multitasking.
Thanks. We have a couple questions from Derek. One is about access to mental health services, and he is describing that they have a lot of patients with who need mental health services without a lot of providers, and he's wondering what your experiences have been with mental health care, and he's also wondering about experiences you've had with transportation. If you've had a lot of clients that you think have taken advantage of transportation services unfairly, perhaps.
Savvy, I'd like to jump in on this one.
Go for it.
When it comes to mental health, I can tell you upfront and personal, this is framed in the intake process. The intake process is pretty much the buffer that assesses the client's barriers to care, and we have the behavioral health services staff do a complete screening on mental health, behavioral health, and any kind of substance use and misuse. So those things are captured upfront and personal. When it comes to transportation, I can assure you, we have a dedicated CHW who coordinates transportation, whether a person is Medicaid eligible or whether or not they would be requiring a gas voucher or a bus pass. As Ryan White being a payer of last resort, we may have to resort to a taxi cab. But the moral of the story is we have a dedicated coordinator who is handling that. So this CHW would be red flagged by any abuse or misgivings of a client taking advantage of our resources. We do have financial budgets that have to be set and mandated. So we don't have any issues because we have a dedicated CHW who coordinates. And I'm talking about clients that don't only have a specialty care appointment with the ID provider, but we try to coordinate if that client also has a primary care appointment or a dental appointment. So it's quite intense that we monitor that very closely so we don't run into any kind of abuse, if that answers your question.
Thanks so much, Peter. Do you want to add anything? I think we just have time for one more quick question, unless you have anything to add, Savvy.
No, Peter deals with transportation a lot more than I do. We only do bus passes.
Yeah, great. We have an anonymous question asking if you could talk just briefly about your no-show rates and how your agency in general sort of addresses no-shows. Do you offer walk-in clinics? What are the different things you do to address no-show rates?
I would love to touch on this one because this is probably my biggest issue with clients. Is not only am I dealing with clients that are already difficult to get in, but they regularly do not call to cancel their appointments. So my no-show rates are very high. I would say something in the range, last time I think I checked, it was like 40 or 50% of my clients are no-showing. I address that by regular constant reminders of appointments. I follow up with clients after their appointments. If they miss, I'm going to call the next day or that day to reschedule them. So it's kind of constant attention to address it. We have some walk-in slots and we have some same-day appointments, but those can get pretty difficult, specifically for clients who are returning to care. They need a longer appointment slot than just a same-day appointment. So for them, sometimes I have to book out pretty far in advance, which requires just more attention. So as I touched on in the slides, that would maybe be a client that I would be more regularly keeping in contact with just so that they attend their appointment. But no-shows is also something our clinic deals with and struggles with sometimes for sure.
Savvy, I would just add that we do have a dedicated coordinator that does call the client when it comes to a provider that has to go to the hospital for follow-ups. We may have to bump clients from an original appointment time and date. So we actually do have someone that completely coordinates that whole thing. As far as our caseloads, we have the luxury of being proactive and calling the clients and getting a confirmation as to whether or not they are going to come. So I know from the personal standpoint of the CHWs in my clinic, we basically do monitor that a little more closely based upon our own caseloads, because each client, even though they may have a CHW, they also have a medical case manager. So they have several people calling them, inclusive of this coordinator that may be working a bump list for providers that have had to change their clinic and their appointments. So we do have a lot of safety nets in place. So we do work diligently on that no-show rate.
Thank you all so much. Thank you, Peter and Savvy, and thanks to all of you attending. Apologies for ending the webinar a couple minutes after 3 o'clock. When you sign out of the webinar, you'll receive an email with a link to a very short poll. We're really grateful for any feedback you can provide to us on today's presentation, so thank you in advance for completing those short questions. As I mentioned earlier, this webinar is the third in a series associated with this initiative. So you can visit Target HIV or our project website to learn more and also access the other webinars in the series and to review related resources. We'll be posting a recording of this webinar as well as the slides and later on the questions and answers that you all have asked us. Feel free to contact us if you have more questions or want more information about the project. We're going to end the webinar now. Thank you all again so much and have a great day.